So before we get into the first speaker of the night, I'd like to introduce Michael. Michael just wants to quickly talk about, I think, what's up on the screen.
Hi everyone, my name is Michael Estepa. I'm the clinical nurse consultant for our Southwest Sydney Local Health District, our Drug Health Department. I work closely with Dr. Jenny James regarding the GP service that we're providing to general practitioners within this service for patients with substance abuse issues. One of the services that we provide is a helpline that's open Monday to Friday, 9 to 5, excluding public holidays and weekends. And one of the aims of this service is to provide support to general practitioners such as yourselves in managing patients with substance abuse issues. And the good thing about that is that you have someone who works within the district itself. Before I go in a little bit more about that, I'll just talk very briefly about myself. Prior to joining this project, I was a respiratory medical nurse at Liverpool Hospital. I then went on to work with the drug and alcohol team consultation liaison at Liverpool Hospital, frontline nurse, doing that for the last 4 years before coming over onto this project. And with that experience, it allowed me just to gain a bit more intimate knowledge of what services are available within our health service across the Southwest Sydney district. And one of the services we offer is when you're able to call through, your advice can be either particular for a particular patient or general or in something in general. So if you're calling up to find out what are the referral pathways for getting patients into detox, rehabs, counselling services, I'll be able to guide you in that. If you wanted to be a bit more specific and find out, what would I need to do to get a patient of mine into a detox program, I work very closely with the nursing unit manager and the medical specialist in our Corella Lodge detox unit at Fairfield Hospital. And depending how our conversation would go, for example, I would either advise you, I could organise that face-to-face appointment with one of our intake officers, or if it's a bit more acute than that, I would either advise you to call the ambulance, or I could speak to the nursing unit manager to find out when the next bed would be available and kind of facilitate that process to kind of speed things along. If there's more information regarding certain patients about what pharmacotherapies are available, like the different OSTs, how to get patients that are identified as having codeine dependence or abuse and wanting to find out what's there, we have different OST units that we can refer you to or try and guide you towards which direction to get patients either on the methadone or Suboxone treatment. So things like that, or even things like trying to find out what are some of the ways to prevent relapse prevention. For example, the use of a camprosate and naltrexone, those types of medications I'd be able to advise you, because the other person you'd be speaking to is essentially me. I'm the one you would be speaking to on the other end of that line. The only time you wouldn't be is if I had an ADO, but in which case there'd be someone really experienced as well to answer that phone call. The other thing as well is that if I don't know the answer to that question, I also do have medical backup. So I could always liaise with Dr. Jenny James or any number of our medical staff specialists in addiction medicine who I can speak to as well to gain that information. One of the things as well that we've also, as part of this service that we also do, is we also do case conferences with patients that enter our detox units. So what I mean by that is, for example, let's say a patient comes into a detox unit and they've completed the detox and they also have a GP already at their disposal. What can then happen is I would speak to the patient and find out, one, if they already have a GP, and assuming they do, I could then liaise with that medical practice with this patient's consent and then find out if they're interested in organising a case conference with their GP on discharge. And in that same process, I'd also organise a global care plan, just so that when they discharge from the detox unit, their transition into their appointment with their next GP is continuous and it's a smooth process. I had a case conference today with a patient today who completed detox on the 24th of November, and he had his case conference today with his GP. And in that, it was great because I was able to not only provide that global care plan and that discharge summary, but also essentially liaise what happened during that detox. Because oftentimes patients, one, don't always often disclose that they've done a detox for fear of that stigma or shame factor part of it, and it kind of cuts through that and allows them to say, this is what I did, and also identify to the doctor, this is what happened We've started the patient on Avanza, we've started them a camprosate, and just giving a bit of that more advice on what to happen post that case conference. So that's something that happened today, and the good thing about this case conference that happened today is that it went beyond the substance abuse. The GP was able to focus on what other things bothered this patient. This patient was concerned about his general well-being due to years of neglect, so there was things like cholesterol, diabetes that they're able to talk about, follow up on blood tests, and anything else they wanted to go on. So that's another service that we do offer as part of this project as well. And generally speaking, the feedback I've been getting from the patients is that they're happy to get me involved because it's essentially just like they have a familiar face that's able to liaise all of this to their GP. And then once that case conference is over, the GP then just takes over the medical side, and if there is any concerns, they can always liaise with me. And often when they are discharged from the Corella detox, there is already a discharge plan from Drug Health, either a day program, some kind of rehab follow-up, counselling and things like that. So so that's just briefly about the service that we provide that I'm working with Dr. James on. So thank you.
You'll also find a brochure about that service with all the information that you got today. So you don't have to necessarily write down that number. It should already be some there for you. So first we'd like to introduce Dr. Jenny James. Dr. Jenny James is a general practitioner and currently coordinates the Primary Health Care Drug and Alcohol Support Service at South Western Sydney Local Health District. She previously worked at the Mount Druitt Aboriginal Medical Service for 24 years and coordinated the activities of the AMS Substance Misuse Program. Jenny is a GP supervisor and she has a Master's in Psychological Medicine and is registered to provide focused psychological therapies under Medicare. Jenny is also a conjoint lecturer with the University of Western Sydney, Western Sydney University, and enjoys engagement on various advisory committees relating to drug and mental health. So I'd like to welcome Dr. Jenny James.
Okay, hello everybody, and thank you for all coming. I'm just going to, just before I move that slide on to the next one, is just draw attention to the third point on that, which is that in New South Wales, GPs are able to prescribe opioid pharmacotherapies, which are methadone and Suboxone, that's buprenorphine naloxone, to up to 5 patients, even if they haven't done the training course, which leads to accreditation. And we know that there are a lot of patients who have been on those pharmacotherapies for quite a long time and are very stable, so their opioid dependence is very well treated. They're not using any other substances, and they are so keen, they are keen as mustard to try and find GPs who are happy to talk to them about something other than their methadone and their buprenorphine treatment. So they love it if they can access general practice services where, as well as being able to get a script review, someone can have a conversation with them about their renal disease or their diabetes or their cardiovascular risk factors. So we are there to also support any GPs who might be interested in moving into that space. So if anybody does want any support with how do you look after patients on buprenorphine, it's really quite simple, but please contact myself. My details are on the 3rd slide, or also you could contact Michael and we can talk to you about that, and we can provide case conference inside your general practice to get you going with that as well. So I just wanted to quickly touch on that. And one more plug before we get going on the topic, which is this is the RACGP with South Western Sydney and Western Sydney PHN are putting on the AOD 18 Drug and Alcohol Workshop Conference for general practitioners. So that's got the date and the time. It's free. All you've got to do, it's a fantastic day. It's been run already up in the Hunter, New England, and also in central Sydney. It's had really good feedback from GPs. The College of GPs, I think, has already just put out one expression of interest, and they've already got a lot of people putting their hands up. So it's 40 CPD points as well. And it's going to, as one of the topics, probably touch on the codeine rescheduling issue amongst a whole lot of other AOD issues. So if you're interested in that, I highly recommend that. So, and if you are interested, I'd suggest you register as soon as possible. Okay, so these are the learning objectives, which you all would have got before the evening as well. So we want to try and look at How do we identify contributing factors and common associations of mental health and AOD comorbidity? How do we structure screening and assessment in relation to comorbidity? Understanding engagement strategies for this group of people, formulating appropriate management strategies for people with comorbidity, and hopefully you'll be able to develop a knowledge of referral mechanisms and support networks in southwest Sydney when organising care for a patient with comorbid drug and alcohol issues. So this is how we're going to try and structure this presentation. So our first thing we're going to look at is what do we actually know about comorbidity. So essentially what comorbidity means is it's the co-occurrence of an AOD or any sort of disorder with another disorder in a specified time frame. And tonight we're talking about the co-occurrence of AOD use disorder with one or more mental health disorders. And there are of course lots of other comorbidities which can include comorbid AOD use where you've got several substances used, or you can have an AOD disorder with a physical health disorder, you can have an AOD use disorder with intellectual or cognitive disability. So comorbidity is simply the co-occurrence of one or more diseases in an individual, and tonight we're focusing on the co-occurrence of AOD and mental health. So how common is comorbidity? So mental health and substance use disorders are two of Australia's most common chronic conditions, and 1 in 5 Australians will undergo either an episode of mental health disorder or substance use disorder in any given year. And 1 in 3 people with a substance use disorder have got at least one co-occurring anxiety or affective disorder. And we know that at the point when people are entering treatment for an AOD use disorder, there's an extremely high rate of concurrent mental health issues. And about 3/4 of people at that point, when they're entering treatment, are likely to have a coexisting mental health disorder as well. And if we flip this and we look from the other side, from the mental health end, we've got data from a major US study where 1 in 3 people with serious mental illness also have a problem with a substance, and the risk for developing a problem with illicit drugs is particularly much higher than the general population. And we also know from that study that there are particular mental illnesses where comorbidity is likely to be more common, and that includes some of the very disabling mental illnesses like schizophrenia and bipolar disorder. And in Australia we've developed the ability to measure rates of comorbidity with the first national survey of health and wellbeing. And the first one was conducted in 1997 and it was repeated again in 2007. And this plus other population surveys confirms the same thing as was found in the US study. So there are specific populations of people who are more likely to suffer from comorbid conditions, and they include populations of people who are homeless, and I mean that in a very broad sense of the term. So sleeping rough, but also couch surfing and staying with friends or staying in refuges, or perhaps being in a boarding house or a caravan park with no secure lease. People who have polydrug use are very likely to have a comorbid mental health condition. People with severe depression and PTSD have got particularly high rates of concurrent comorbid conditions. Lifetime psychotic disorders, as I've already mentioned. And another very important population to know about is the prison population. So many people have comorbid conditions there. And of course, we will sometimes be seeing people who have spent time in prison when they're released and they come out into general practice and see us as GPs. So outside of general practice, in our communities and families, we've got information from the Australian Institute of Health and Welfare's pooled data. That tells us that almost half, about 45% of Australians are going to experience a mental illness in their lifetime. And against this background of high prevalence in the general community, we've got information from the BEACH program, which some of you probably know about that. That was a continuous national study of general practice activity, and it was begun by Sydney University in the late 1990s, was collected every year, and it went right through to 2016 and then really sadly lost its funding, but we've still got that recent data.
I think the funding is going to be
Oh yay, Francis is telling us the funding is going to be reinstated. That would be really good. Okay, so I'm just going to do a straw poll now, so it's just a hands up thing, okay? So I would like to see what you think about what the correct answer to this is. So your choices are that depression is the second most common managed chronic problem in general practice. Depression is the 5th most common managed chronic problem in general practice. Depression is the 8th most common managed chronic problem, or it is the 20th most common managed chronic problem in general practice. I'll give you 5 seconds to think whether you want to go 1, 2, 3 or 4. Okay, who's for a 1? Who's for a 2? Who's for a 3? Anyone for a 4? So the ones have got it on this one. So it is the second most frequently managed chronic problem in general practice, and anxiety is the 5th most common problem managed with a clinical treatment in general practice. And if you look at the comparative Beach data, comparing 2006-7 to 2016, 10 years later, it's also very interesting because it shows us some of the changes that took place in general practice over time. And over that decade, depression was managed on 2.2 million more occasions in 2016 than it was in 2006. So it's incredible when you think about that. Depression also is the problem that accounted for the largest proportion of allied health referrals that GPs were doing in 2016. Okay, so I'm just going to do another quick straw poll, which is what percentage of patients attending general practice are consuming at-risk levels of alcohol? And I guess first we're just to define what at-risk alcohol consumption is. There's sort of 4 components to that. So less than or equal to 2 standard drinks, and that's men and women, on any day will reduce the lifetime risk of harm from alcohol-related disease. Less than or equal to 4 standard drinks on a single occasion reduces the risk of harm from drinking on that occasion. And for young people under the age of 18, the safest option is to delay drinking, don't drink any alcohol. And the other special group is, of course, women who are pregnant or breastfeeding, and the recommendation is 0 alcohol. Okay, so I'm just going to give you 5 seconds to think whether, and this is based on Beach data, so general practice data, what percentage of your patients do you think are consuming at-risk levels of alcohol? 1%? 5%, 10%, 25% or 50%. So I'll give you 5 seconds. Okay, who says 1%? Anybody saying 5%? Anybody saying 10%? Anybody saying 25%? And anybody 50%? Okay. So the answer is 25%, and that's what's come out of general practice data. So 1 in 4 patients seen in general practice are consuming at-risk levels of alcohol. And we find that it's most prevalent in those who are aged 18 to 24 years, and it's particularly more prevalent in males. And in that age group, that younger age group, it's about 40% of males, and it's approximately 30% of females who are reporting at-risk levels of alcohol consumption. And the Beach data also accessed information about alcohol consumption. It got it from the Audit C tool, which is on your medical software, and we'll come back to that in a minute because I want to talk about that a little bit. So just hold that thought that 25% the attending population are consuming at-risk levels of alcohol. So alcohol far outweighs other substances in terms of presentations into general practice, but it is important to know about other substances because you will see that present as well, and in particular benzodiazepine use and problems with opioid dependence. The other thing I wanted to do is just draw your attention to the changing patterns of opioid misuse in Australia over the last 10 to 20 years, because there has been a dramatic shift in what is actually happening in the population. And the move has been away from illicit opioids like heroin into the pharmaceuticals like OxyContin, fentanyl, morphine, these kinds of medications. So we've got data, for example, in 2009, the medically supervised injecting centre in King's Cross showed the main drug injected on site there was heroin. 5 years later, in 2014, it had radically changed, and in a 1 month period, there were 4,000 episodes of injection of crushed, dissolved prescription opioid medications, and there was about 1,000 episodes of injection of heroin. So that's the kind of opioid landscape that we're in. And the Beach data tells us, the data that we've got from 2014 showed oxycodone to be the 7th most common drug prescribed in general practice. And I'm drawing attention to that because we're getting a lot of data now about how dangerous prescription opioids are. We know, for example, for the decade between 2001 and 2012, that more than 800 Australians died from the use of the prescription painkiller oxycodone. And the coroner's reports show that the majority of those deaths, they were not self-harm deaths, they were actually accidental deaths where people probably went to sleep and didn't wake up because they had a significant degree of respiratory depression.
It's interesting that the data just come out from the general United States, the health department, that the United States every day there is 190 young people are dying with prescription medication every day.
Yeah, I don't know if you've heard.
That issue in the United States is
So Francis was saying that in the United States the data is showing 190 people dying every day from prescription opioids. So if we look at what is happening across Australia in our community and families, the National Drug Strategy Household Survey is our source of information on both legal and illicit drug use. It's probably not perfect because it basically involves someone coming and knocking on your door and with a survey and saying, "Hi, I'm from the government and I want to collect information on your family's drug and alcohol use." But it's what we've got, and it does provide us with some useful data. It's repeated every 3 years. And it surveys use and attitudes to drugs. So in this graph, the dark blue lines represent percentages of people who say they've ever used a particular substance. Purple lines indicate the percentage of people who say they've used the particular substance in the last 12 months. So you can see, I hope you can see, the big one at the bottom, which is alcohol. And you can see another big one, which is tobacco. And then, so you can see the legalised drugs are dominating our substance misuse in Australia, and we know that they cause the greatest harms in terms of health and disruption of lives from a psychosocial perspective. So here's another straw poll. The question is, who is most likely to have a substance use disorder? Is it person 1, person 2, person 3, person 4, person 5, or person 6, and this is based on our knowledge about gender, age and substance of preference in Australia. So I'll give you 5 seconds to settle on a person. Okay, who would say person 1? Person 2? Person 3? Person 4? Person 5? Person 6. Okay, it is person 5. All right, so it's that young male age group. We know that in that group alcohol is of a particular concern. So obviously what I'm doing now is drawing attention to the harms that come from alcohol. So these figures show us that over 1 in 20 Australians have actually got an alcohol use disorder. Staggering 40% of emergency department presentations include alcohol as a contributor to that presentation. 30% of hospital admissions are related to alcohol in some way, and about half of all the AOD consultation liaison activity is about alcohol. One more straw poll. What's the median time it takes for an Australian with an alcohol use disorder to seek any sort of treatment? So your choices are 6 months, 12 months, 3 years, 5 years, 10 years, 18 years, 20 years. Okay, who thinks it's 6 months? Okay, this is the time it takes for someone to seek treatment. Does anyone think it's 12 months? Does anyone think it's 3 years? Okay. 5 years? Okay. 10 years? 18 years? 20 years? The answer is 18 years. The reference is down the bottom of that slide. So as we head into talking about comorbidity of drug and alcohol mental health, it's important for us to hold in our heads, I think, that idea of there being a spectrum of risk associated with psychoactive substance use. So some people will say, that a small amount of substances are maybe even beneficial. There might be no evidence of ill health effects. Sometimes people use substances in a non-problematic way. It is possible to do that. So they have no health impact, they have no social impact. Substance use is casual, infrequent. But of course then there's the problematic part of that spectrum. So drugs can be used in a potentially harmful way, and that might be, for example, drink driving, binge alcohol consumption, or sharing your injecting equipment, causing distress to other people in the family because you've used a substance. And then there are what we call substance use disorders as defined in the DSM-5. So the DSM-5 criteria, it changed the area of substance use quite a lot compared to DSM-4, and it came up with this idea of substance use disorder. What they used to have was a separate category for substance misuse and substance dependence, and that concept is sort of was for various reasons not found to be particularly useful, a bit problematic. So the essential features of a substance use disorder, it's a cluster of cognitive and behavioural and physiological symptoms that indicate that the individual is using the substance despite there being significant substance-related harm. So we're hoping that using that term too will reduce all that confusion there is around the words and terms like dependence and abuse. And we think that this term is probably going to be a lot more acceptable to patients as well and their carers. A diagnosis of being drug dependent is quite stigmatising. So a diagnosis of a substance use disorder basically needs 2 of those 11 criteria, okay? And they cross over basically 4 categories. There's impaired control of the substance, social impairment that happens, risky use, and pharmacological dependence. And one very practical point about this is to know that GPs can do a mental health care plan with a patient if they have got a DSM-5 diagnosable disorder. So if they don't have a mental health disorder and they have got a substance use disorder, you can do a mental health care plan and claim under that because it's a DSM-5 diagnosis, okay? And it's very, very underused, I think. So these criteria obviously apply to any substance, be it alcohol, heroin, benzodiazepines, cocaine. Essentially, obviously the higher the number of those things you have going, the more severe the disorder. Okay, so if we move on to thinking how does comorbidity occur, there are several possible ways. So the substance use disorder might be a consequence of the mental health condition. This is often described as a self-medication hypothesis, in that substances are used to try and medicate the mental health symptoms that a person's getting. Or the mental health condition might be a consequence of their AOD use. For example, Alcohol use and withdrawal can induce symptoms of depression and anxiety, or manic symptoms might be induced by intoxication with stimulants or steroids or hallucinogens, or psychotic symptoms can be induced by withdrawal from alcohol and also intoxication with amphetamines. There can also be an indirect causal relationship, so mental health condition has an effect on an intermediary factor which then increases the chance of developing a substance disorder or vice versa. So an example of that would be a depressive disorder might lead to difficulties completing study or work, and that in turn leads to difficulties finding employment, and that in turn increases the risk of AOD use. The co-occurrence of mental health and substance disorders can also occur because of there being shared biological, psychological or environmental risk factors. So for example, both substance use disorders and mental health disorders being associated with lower socioeconomic status, cognitive impairment, conduct disorder as a child, and obviously also genetics. And I guess the big question is, does the causality matter? So establishing the order of onset of conditions can be useful in understanding the relationship between the conditions, but it's important to note though that once comorbid conditions have been established, it's likely that the relationship between them is one of mutual influence rather than being a clear kind of causal pathway. So regardless of how the comorbidity came about, both conditions are probably serving to maintain and exacerbate each other. So, a person might engage in AOD use to reduce their symptoms of anxiety, but, we know that repeated use can actually lead to increased anxiety. So the harms associated with comorbidity are highly significant, and the presence of comorbid substance use disorders and mental health issues is associated with markedly poorer physical health outcomes and difficulties in key relationships with partners and children and parents, with finding an occupation, moving into situations that come with legal and financial difficulties where there's accumulation of debt. Incarceration is more common. There's an increased risk of self-harm and suicide, and reduced life expectancy for people with comorbidity as well. So obviously big challenges for the patients, big challenges for families and carers, challenges for us as GPs as well, and challenges for the health system to come to grips with. So people with these comorbidities die 20 to 30 years earlier than the general population, and they often spend the last 10 years of their life with very disabling chronic illness. So that's quite an astounding life expectancy gap. So I think a large part of the problem for people trying to access treatment is that our clinical service has often adopted, services often have adopted that siloed approach in which mental and substance use disorders are treated separately, and as a consequence people get bounced around quite a bit and they sort of fall through the cracks. So people with comorbidity often have difficulty too, I think, navigating their way through these different services, and that can be hard even if you're quite well. There's multiple options, there's different entry points, there's different criteria for the services, and this is where you could be bounced around like a kind of treatment roundabout, and that's where the term "no wrong door" came from. It came as the term that was used to say, can we please make this a lot easier for patients so that no matter where you go, the door is open for treatment of both your substance misuse and your mental health disorder. Okay, so we've looked at what we know about comorbidity, so we now want to look at how we identify it. So in general practice, we're sometimes aware of coexisting mental health and drug and alcohol issues in the same patient, but we often become aware of one of those issues before the other. So therefore, every patient with a mental health issue should be assessed for coexisting substance misuse problems, and every patient with problems with drug and alcohol use should be assessed for coexisting mental health issues. So this obviously applies to patients we don't know very well, or patients who are new to the practice. But it should equally apply to regular attendees. For example, you know, we might be seeing a long-term patient with schizophrenia, say, who attends for general health care and depot antipsychotics. They have a history that 20 years ago they used to drink heavily, and they were abstinent for many, many, many years, but for various reasons recommenced drinking again. And we're not going to know that unless we keep reassessing for substance use. So there are 5 key questions to ask when taking a drug use history, and they're up here. They're the conversation openers, and they pretty well cover everything that we need to know in order to provide good health care. They give us the information that we need to look after a patient's mental health. So the questions are simple, they're non-judgmental, and I often preface them by asking permission to ask about drug use. And you might get a no to all 5 questions, in which case there's no comorbidity. But if we get a yes to any of these queries, we need to explore with more questions. So you can see that we're asking about current drug use, both legal and illicit, and past drug use, including a past history of injecting drugs. With the third question, which is the one about, you know, do you use any other drugs? I always like to follow up with examples because I think it helps give the patient permission then to talk about any illicit drug use. And they'll feel more comfortable if they know that we as a GP are just used to talking about those drugs as part of a standard consultation. So my examples also mix up, you know, illicit and prescription drugs of misuse because both can cause potential harm. Okay, so let's suppose a patient had answered yes to the third question and told me he was currently using some OxyContin, and you'll see on this slide a summary of the questions you need to ask about illicit drug use. And Ben and I are just going to do a real quick demo now of history taking. And you'll see the summary of the sorts of questions that should be covered up here on the slide when we're taking a history of substance misuse. So I think Ben's becoming Jason. I'll just be Dr. Jenny. Okay, so when we're asking about alcohol use, you can ask some of those questions that we've demonstrated. In fact, you can probably ask all of them, except obviously the one about injecting is probably not so relevant. But I would encourage everyone to use the Audit C function on the Medical Director Best Practice software. So the audit's the recommended screening tool for alcohol use, and it was developed by the World Health Organization. And our medical software has got that shortened 3-question version. So here is the Audit C. So if the answer to the first question is 0, you don't continue to ask any further questions. A score of 4 or more indicates the need for further assessment, and you'd need to feed that back to your patients, that it's possible that their alcohol use might be causing some health harms, and to assess that, you'd like to ask some more questions. So Ben and I are going to do another brief little Jason up here. Yeah. Okay, so that's just using the Audit C part of... Okay, just a quick reminder at this point about what a standard drink is. You've probably seen these visual charts, and they're readily available. This is just downloaded from www.alcohol.gov, and it's really useful to show patients what constitutes a standard drink, because we all tend to overestimate the amount of alcohol that is in a standard drink, unfortunately. So we're going to jump into a case now so we can talk through the next questions and perhaps demonstrate how assessment and management of comorbid disorders work in general practice. So Brendan is aged 25 years. He's attended your practice for minor illnesses throughout his childhood, returns now as a young man after a long hiatus. He'd like the sutures removed from his scalp. He had a fall outside a pub 1 week ago, had a laceration, wound healed well, and he feels fine. So you ask Brendan what happened when he fell over, and he says he was out with some mates and they overdid the drinks a bit. You take a look at the laceration that's healing, and you decide to start asking him about his substance use. So how would you begin your assessment with Brendan? Has anyone got any ideas? Quiet. You could start with your alcohol audit C, yeah?
I think we start with the fall, because sometimes some patients, they don't like to clarify about the alcohol straight away.
Yeah, so, and sorry, what did you say? You start with the...
With the fall, what was the reason for the fall?
The reason for the fall, that's right, yeah. So it's sort of coming in from a side angle, isn't it, rather than coming straight out with it. That is a good way. And that might lead you on to doing the audit C. And would you stop there in terms of your substance use assessment? No. So, you know, you'd ask some questions. You'd then, I think, look for some specific harms from alcohol. So they'd be harms like any history of acute intoxication or episodes of unintentional harm, haven't had any falls, been involved in any assaults, any road accidents, any seizures, any driving licence issues. So let's say as a result of talking to Brendan, he tells us that he fell after an indeterminate number of drinks. And he has about 10 or more standard drinks on Friday nights, and on other social occasions as they occur. He's got an audit score of 8. Had a drink driving offence 2 years ago, licence suspended for 12 months, no motor vehicle accidents, no work absenteeism. He feels guilty about his drinking. He'd like to cut down. Previous minor head injury after a pub brawl about a year ago. Uses 1 cone of cannabis, or used to in the past, hasn't had any for 2 years. What other questions about his alcohol use might you ask at this point? So that's looking at harms. So you might look for dependence. There is a questionnaire called the CAGE questionnaire. Does anyone use the CAGE questionnaire? C-A-G-E? No? Yes? Okay. So, I mean, it's essentially 4 questions that are good for looking to see if there is dependence on a substance. So it's, have you ever felt the need to cut down on your drinking? Have people annoyed you if they've ever criticised your drinking? Have you ever felt guilty about drinking? And have you ever felt you needed to have a drink first thing in the morning? So let's say Brendan says no to at least 3 of those things. Shows he doesn't show high signs of dependence, but he's still drinking at risky levels, isn't he? Because he's got that sort of binge pattern of alcohol use. So let's say we continue to ask him some psychosocial history, and he tells us that he works full-time as a landscaper, broke up with his girlfriend 6 months ago, lives in a 1-bedroom rented accommodation, no debts or financial difficulties, sleep okay, appetite good. And he says, I get a bit of anxiety. So you've got something significant, I think he's telling us there. So he's got a potentially harmful pattern of drinking, and he's mentioned that word anxiety. So we want to follow that up. So there might be some medical differential diagnoses there, which you might want to, you know, when you question, make sure they're not there, you know, things like hypothyroidism or cardiac disorder or something like that. But let's suppose there's no evidence of a medical cause for his symptoms. You then want to look for specific features of anxiety disorders, okay? So what questions might you ask about anxiety? Anybody want to have a go?
Anxiety could be related to either family history of anxiety.
Sure, yeah, family history.
How the anxiety proceed in his family.
Yeah.
And then you have to know to assess the severity of the anxiety.
Yes.
So how bad is his anxiety that stop him from doing his work, socializing.
Yeah, how does it impact? Yeah.
And whether it affects him for the level that he takes some drugs or honestly drug addiction or alcohol, or how he deals with his anxiety.
Sure. What strategies does he have for dealing with his anxiety? Yeah, that's really good. And what does it feel like? What symptoms does he get in his body? Yeah.
Physical symptom or only psychological symptom?
Yeah. You can ask, have you ever had a panic attack? And explain that's when you breathe fast and you get a sense of dread, you feel you're either going to have a heart attack or die.
One of the things that, I mean, he's 25 years old.
Yep.
With anxiety, you really have to ask, you start at school.
Yeah.
You start in adolescence.
Yeah.
You start in a relationship.
Yeah.
So when did it begin?
Yeah.
And so that's important that did it happen at school?
Yeah.
So you really have to have recently or he's been suffering from.
Yeah.
That's important to really extract in anxiety. That did he suffer at school?
That's right.
And things like that. So I think anxiety just itself, you can ask where did it start. So
That's right.
it's important.
Yeah, so it's getting that history of longevity, and it gives you clues into much more clues into what's actually going on there. And you can ask what makes it better and what makes it worse. They're key questions too. And you would ask about his mood. And obviously, if Brendan said his mood is low, you then need to go on and ask some questions about whether he has depression or not. But let's say he says his mood is generally okay. And he says he drinks to calm my nerves. And he says that he has had panic attacks and he gets them when he enters a room full of people he doesn't know. He avoids eating in public because it causes a lot of anxiety, and he worries all the time that people are going to think he's some kind of a nerd when he's in conversations with people he doesn't know very well. His mood's okay, no sleep or appetite disturbance. He has a K10 score of 26. You can also use a DAS, D-A-S-S. Everyone familiar with the K10? Yeah. Okay. And it's good to do that because it helps us track improvements in management. And of course it's required as a part of the mental health care plan as well to do some sort of psychological assessment tool. And it also helps patients, I think, to engage in a reflective process about what's going on. So I think with that description, you can see there's an emerging picture of social phobia, maybe. Panic attacks with a sort of a pattern of risky drinking. So that'd be a common kind of comorbidity. What might be another thing at that point, another kind of assessment it might be important to do? So a risk assessment. Just essentially checking to make sure there's no self-harm intention, and asking about harm to others as well. And there's another important question to ask, which is the one that I asked in that first interview when we were talking to Jason, and it was, have you thought about changing your use, or have you thought about cutting down? So that's the golden question, and that's the question about change. And you can ask that in several ways. You can say things like, on a scale of 1 to 10, how important is it for you to make a change? Or if you were to make a change on a scale of 1 to 10, how confident would you be that you'd be able to decrease your alcohol use? Or is change an immediate priority for you with regards to your alcohol use? So you're trying to assess readiness for change. And probably most of you have some familiarity with the stages of change model, which I haven't got time to go into in detail, but it's the kind of lead into motivational interviewing. And the stages of change model basically proposes that when we first meet patients with AOD problems, they're likely to be sitting in one of those stages, and that as patients pass through those stages, they try to make changes around their drug use. And motivational interviewing can be used at any one of those stages. It's particularly effective when we use it in the pre-contemplation and the contemplation and the determination phase. So after you've done an assessment, it'd be important to interpret the results for the patient. So important to say something to Jason in a manner that he can understand. Not just by giving a numerical K10 number, but you want to feed back assessment results and focus on his strengths first. That's what I would do, and just gently and tactfully kind of outline what the difficulties are, and focus on the kind of pattern of results, rather than just that overall score, and try and pull your assessment together and offer hope for the future by saying, okay, now we're going to work on a treatment plan. So, in Brendan's case, it seems pretty clear that he's got a concurrent social anxiety disorder with his alcohol use disorder, but it can be hard to know if the symptoms of mood or anxiety or psychosis are primary in nature, or induced by substance use or withdrawal. So there are some examples on this slide. So alcohol use withdrawal can induce symptoms of depression or anxiety, and manic symptoms can be induced by intoxication with stimulants, okay? So when we're trying to sort this kind of stuff out, we need to know, do the mental health symptoms only occur when the person is intoxicated or in withdrawal? Have the symptoms continued even after the person has had a period of abstinence? Do the symptoms change when our patient stops using substances? Is there a family history of a particular mental health condition, because some of them do have quite strong genetic predispositions?
This is where most and this is where being a GP and as well as a prescriber, I think this is exactly the time when GPs can get caught up in benzodiazepine prescription.
Right.
This is exactly because his anxiety, his alcohol problem, and I think I'll give you some Xanax or give you some Valium and go ahead, to take your symptoms off. And this is where most GPs get stuck by getting at this point in time. Because you made an assessment and he's got anxiety and okay, he's got alcohol. So this is where benzos come in. All my over the 20 years, this is like, I had a bit of anxiety, and my GP gave me some Xanax, Valium, and then it went up to Xanax.
Yeah.
And it's an absolute disaster.
Yeah.
It's exactly here where anxiety, sort of, we can get trapped.
Yeah. Yeah. So I hope everyone heard Francis's very strong words of wisdom from long experience, because it can be a trap, and it's to reach for the quick fix, and it's usually not helpful. I'll just touch on there are particular difficulties too in distinguishing between substance-induced psychosis and primary psychosis such as schizophrenia. That's been one I've seen in general practice. It's often a bit difficult, but substance-induced symptoms tend to appear quickly. They tend, not necessarily always, 100% of the time, but they tend to last a shorter time, so for hours or days or weeks. And visual hallucinations are more common in substance withdrawal and intoxication than in primary psychotic disorders. Okay, so just recapping on what we've looked at so far, we've talked about those first two questions. Now we're going to have a look at developing a plan for holistic care and management and treatment. So when we're formulating a plan, we need to take a holistic approach, a person-centred approach that looks at the person's needs rather than focusing on their illness. We're trying to improve the quality of their life across all domains, so physical health, family relationships, as well as mental health symptoms and substance use. And the holistic approach is really important for this group of people because they're at such high risk of developing cardiovascular disease. They have higher rates of cancer, they've got higher rates of smoking, diabetes, poorer diets, they're more sedentary, and they don't have access to health services as much, as they tend to have their conditions diagnosed later, and that includes getting things like cancer diagnosed later, so the prognosis becomes much worse. So we want to help people stop smoking, we want to encourage them into physical activity, we want to encourage them into healthier diets and encourage them to adopt healthy sleep patterns. And these things are really important, and I think if you don't brush over them, talk really seriously to the patient about them and really sort of push that with the patient, that these things are actually highly therapeutic management tools. So Brendan has got comorbid conditions of social phobia and at-risk drinking. So there are different models of care talked about when you've got that sort of coexistence. You can have sequential treatment, and that's when the patient's treated for one condition first, and it's followed by treatment for the other condition. And with that model, the AOD use is typically addressed first and then the mental health problem. But in some cases, it might be whichever disorder is considered to be primary. Then you've got parallel treatment, and that's when the patient's AOD use and mental health conditions are treated simultaneously, but the treatments are provided independently of each other. And the treatment for the AOD use is provided by one treatment provider or service, while the mental health condition is treated by another provider or service. And then we have integrated treatment, where the AOD use and the mental health condition are treated simultaneously by the same treatment provider or service, or it's being coordinated by the same treatment provider, such as a GP. And that obviously allows for the exploration of the relationship between the person's AOD use and their mental health condition. And it's the integrated treatment model that we really push. And it does seem to have some evidence base that that's a much better way to go.
I think one of the things that really, if somebody with opiate problem, I think it's empirical that they need, if they got mental illness, the point is first thing is to put them into treatment first, opiate replacement therapy, quick and fast. Otherwise, and then automatically, I think studies have shown that Suboxone, from Italian studies, have shown that Suboxone does have a very good effect on the kappa receptors. And kappa receptors are related to mental illness. So I think I've noticed that if you put them on Suboxone, a lot of the opiate users are using less antipsychotics. Their depression levels may improve their sleeping pattern. So I think first and foremost, if they are chaotic life, we need to have them first of all into opiate replacement first, and then slowly everything else.
Yeah, I think that's, so Francis is talking about where there's an opioid dependency, when if someone is coming in very chaotic and in withdrawal and those sorts of things, it's certainly true. The very first thing you want, if you start is some substitution treatment, and very quickly you're then able to come in with some mental health support. Yeah, I agree with that, yeah. Okay, so there's a range of approaches when it comes to treating comorbidity, and on this slide we've got a good framework that I think works well in general practice in terms of structuring our approaches. The psychological approaches, Annie's going to talk about these soon. There's pharmacological approaches, so there's very little evidence on how effective individual medications are in circumstances where there's comorbidity. You know, all the research has been done on, say, antidepressants is on people who have just got depression, they haven't got comorbidity. So in the absence of any evidence for what we should be doing pharmacologically, it's generally recommended that if you're going to use a medication, use the medication that you would use for each part of that comorbid diagnosis. But always, if pharmacotherapy is going to be used, make sure you use supportive psychological approaches as well. So there's also self-help groups that should be part of that smorgasbord of what you offer people. There are mental health approaches, such as the Mood Gym, for example, that anyone can sort of access free. It's like an online free CBT support for people. Physical activity, very underdone. There's strong evidence that regular structured physical activity improves things like OCD, PTSD, depression. And so if we move back to Brendan, okay, so let's say you've given him feedback and he said he's been thinking about his alcohol consumption, enjoys going out, just letting go once a week, so not really sure whether he wants to change his drinking or not. But he's interested in understanding more about social phobia. What do we do from there? So mental health care plan is obviously a great place to start. So you're working with the patient. And then I think probably some motivational interviewing. And this is right in the domain of the GP. And it'd be great for Brendan because he's in a contemplation phase in the stage of change. So he's not saying no to changing his alcohol use, but he's not really convinced he wants to either. So remember that motivational interviewing is a consultation style where we're trying to guide patients toward change talk. So we don't tell the patient what to do, but we don't just passively sit and listen either. It's like we're guiding them. So we're trying to step into the role of helping our patients find out from within themselves why they may or may not want to change. So we're hoping that the patient can start to look more inwards and ask themselves, well, what are my resources? What can I do about this? What's the first step that I should take? So we're there to sort of nudge the patient towards self-examination. So we've also got options of cognitive behavioural therapy, and there's also dialectical behaviour therapy. There are psychological approaches, including mindfulness therapy, e-mental health we've mentioned, as well, and pharmacological approaches for Brendan. And I just touch on the pharmacological for him. So he has a social anxiety disorder, and the PBS listings are quite relevant here because social phobia is not listed as an indication for use of any SSRI. It's important to know that the management of anxiety disorders with concurrent CBT and pharmacotherapy has not actually been found to be superior in the longer term to using either treatment alone. And some researchers actually consider the concurrent use of CBT, and certainly if it's used with anxiolytic medications like benzodiazepines, to be very detrimental to the treatment effect you're trying to get with the CBT. So it's not a good combination to use benzos with CBT. CBT is what should be used. And research shows patients greatly value CBT and pharmacotherapy, but tend to prefer cognitive behavioural therapy to treatment, to medication for the treatment of anxiety disorders. And they see CBT as more likely to be effective in the long term. So a common rule of thumb is for something like this, you would start with CBT, and if the patient doesn't respond, or if there's significant depression, you might then go on to consider some pharmacotherapy. But if it was a very, very severe presentation of anxiety, you might think about an SSRI. Okay, so I'm going to wind up now and hand over to Annie. This final slide of mine is going to just be about coordinated care, which includes the sort of work that psychologists can do. So, it's very hard to address all of the things that come up there, like, education and family situations that need help, legal issues, help with physical health. It's a big challenge, and managing the active engagement of multiple services across professional and non-professional sectors is pretty challenging. But fortunately, or unfortunately as you might see it, GPs are ideally situated to actually be the coordinator of that care. We're going to, one of the things that we might do is refer to a psychologist, so I think that's probably a good segue at this stage to hand over to Annie.
Thank you, Dr. Jenny James. Round of applause for we might get Dr. James up. Do you want to ask a question quickly? Yeah, sure.
About driving and substance misuse disorders, what's your approach to kind of licensing and like that?
It's you obviously need a thorough assessment. So, and it's about how that substance, you've got to make some sort of judgment of how that substance is affecting that person's ability to drive. If you've got any concerns, or if I had any concerns, I would probably get an addiction medicine review. The New South Wales, I think every state does this differently. So in New South Wales, there's an onus on the patient to report to the licensing authorities if they've got a problem with a substance, but if we as a GP believe that that person is going to be unsafe on the road, there is an onus on us to act in some way, and we need to, I think, get a second opinion. And if we are really concerned and that second opinion is not going to happen, then probably what I would be doing is talking over the phone to an addiction medicine specialist, talking to my medical defence union, and making sure it's okay to notify the licensing authorities, because it is a potentially serious issue. But it's really, though, about trying always to stay with the patient and talking to them about, look, I'm really concerned about this. Have you thought about the effect on the road? That's obviously the main tack, yeah.
Okay, so we're going to have a very short 1-minute commercial break. If you'd like to go to the bathroom, I'll be supplying the commercial, and then we'll get Annie up. So this commercial break is brought to you from the wonderful world of health pathways. I'm not going to talk about health pathways very much because a lot of the people in this room I've met before, and I've talked about health pathways in particular. So I just wanted to point out that at the moment we have the vast majority of our mental health pathways complete and localised on the site. So here we can see it's a bit blurry, but we have a couple for adult and older mental health, including acutely disturbed, which includes drug and alcohol-induced psychosis, as well as other forms of psychotic presentations. Antipsychotic medication, a number of ones for children and youth, including sexualised behaviour, and then most of the crisis presentations that are there as well. We do have, in terms of the requests, most of the mental health requests done. We've got everything but eating disorders listed in terms of if you'd like to know where to refer or how to refer, whether that's through to one of the local health district services, whether it's through to an NGO or to a private provider, we have that information, including what is the process for scheduling a patient. That's all listed here. We do have another one called e-mental health services, where you can just simply print off a 1 to 2 page list, depending on the clinical presentation, of all the different e-mental health services that patient can access within New South Wales. All of them but one is free. The one that costs money is This Way Up, which is $59, but it is highly, has been peer reviewed and has demonstrated efficacy as a result of that. And we also are working on our drug and alcohol pathways. Unfortunately, they're not live yet, but they're over here, and this is on our draft site. So if we were to look at here, so we're looking at alcohol withdrawal. We're also going to be having a pathway on the alcohol interlock program, and a lot of detailed information about alcohol and driving. I just from doing the pathway last week, I did read the RMS indemnifies GPs who do notify about a patient who is drinking and driving as well. So, check that out with your MDA, but that is what the RMS has stated as part of their policies if you go on their site. We're trying to cover all of the different drug and alcohol presentations you may see. Hopefully these will be live by February. That's my goal. It's what I've asked Santa for, and hopefully he will come through with that. And that includes also the request pages. So how to get through to the drug and alcohol specialist services, how to get through for advice, such as the program that was mentioned earlier this evening, and how to access different NGO, private counselling, inpatient detox, residential rehabilitation programs across the district. So that's the commercial breakdown. No one ran away. That was lovely. Thank you. So Anne-Marie is a counselling psychologist and registered psychotherapist, and she's been in private practice for many years and currently runs Mindway Psychological Services in Wetherill Park. Anne-Marie worked in the substance abuse field for 15 years, and she was involved in the original research on the first 330 patients maintained on methadone in Australia. She has worked for 11 years as a senior psychologist at the Wayback Committee. She has also lectured for 3 years at TAFE in the early 1990s, teaching the original advanced certificate in alcohol and other drug studies. She has also lectured social work students at UNSW in relation to alcohol and drug studies. Anne-Marie has also worked in therapeutic rehabilitation centres, and currently she provides expert witness reports in relation to criminal matters. She has also worked in corrective services as a sessional specialist, conducting drug and alcohol groups for inmates. So we'd like to welcome Anne-Marie. And there's your pickup.
So I apologise because my slides aren't as nice as Jenny's. I'm sorry about that. So when I was thinking about what I really wanted to try and achieve in my talk tonight, I was thinking about the comorbidity between substance abuse and mental health problems, and why. Why is there such comorbidity? Why does it happen? So I want to look at that fact and where it comes from. So for psychologists like myself that have been around for a long time and who provide expert witness reports for the court and give evidence in court quite frequently, we are often stumped because none of what's available to us yet gives us a diagnosis for complex trauma. So we did have promises of this happening for the DSM-5, and I know that Bezel van der Kolk and his crew at Boston Medical Centre made a plea to the DSM-5 board for a diagnosis of complex trauma, only for it to be turned down. So at the moment, we are stuck with the diagnosis of PTSD, post-traumatic stress disorder, in the DSM-5. We have been promised that we are going to get the diagnosis of complex trauma in the ICD-11, which was due to come out this year but has now been put off to next year. So we're going to have to wait until next year to find out about that. So why does it matter so much? Because a lot of what you see in psychological practice, and I'm sure a lot of what you see in general practice, comes down to the trauma the person has experienced. And this is why it's so important. So I'm going to endeavour to do this. I'll come back to that. Okay. We did have in the DSM-4 the DESNOS, which was probably the closest we've ever come to the complex trauma, which is the disorders of extreme distress not otherwise specified. But when the DSM-5 came out, it didn't eventuate, unfortunately. So let's have a look at what PTSD actually is. And this is one of the best definitions of the disorder that I've ever come across in practice. And that is that PTSD is a disorder of reactivity and avoidance. And its psychopathology is expressed during interactions with the interpersonal or physical environment. What does that actually mean in practice in every day? A really big part of what you're going to find in psychological practice is disorders of avoidance. Your patients are hoping to avoid memories, they're hoping to avoid smells that invoke memories, they're hoping to avoid places, conversations, anything that reminds them. And this is one of the key links to the comorbidity between substance abuse and mental health problems. Okay, so dissociative responses in the general population are typically transient and reversible, but in cases of protracted stress and trauma, there can actually be two different types of effects. And if you think about this, you can probably think of many of your patients that you've seen this with. The first one is if a child's exposed to severe and chronic stress during their developmental stage, so I normally call that the 0 to 5 stage, they may fail to actually achieve integration of cognition, memory, perceptions and sense of self. If they encounter this distress in their adolescent years, it is different. You actually have fragmentation of self, right? And it's very important to understand that in the presentation that you get with clients. Yes. So I wanted to touch really briefly on attachment theory, which was initially, the theory was started by John Bowlby in the 1950s and the 1960s. And Mary Main went on to develop what they called the strange experiment. And they actually worked out that there were 4 styles of attachment for infants aged 11 to 20 months. And the first one was children with secure attachment behaviours react with distress when separated from their mothers and seek closeness when they return. And the second one, children with insecure attachment and avoidant attachment avoid proximity after separation and typically respond with fewer signs of distress. And 3, children with insecure and avoidant ambivalent behaviours experience distress in the absence of mother but react with aggression when she comes back into the room. And the last one, children with insecure attachment and disorganised and disorientated behaviours respond to the absence with bizarre and stereotyped behaviour, resulting usually from abusive or neglectful relationship with the parent. So when Bowlby and Ainsworth came out with this, there was another PhD student of John Bowlby's, and her name was Prochaska, and she was a PhD student of Bowlby's. And she came out and she said to them, I think you guys have got this all wrong. She said, I worked in social services for many, many years, and the people that you've got in these experiments are actually people, they're parents that volunteered, so they're not typical of the group that we would normally encounter. She actually did a lot of work in this area, and she came out with the dynamic maturational model, and she proposed pathway A, a cognitively organised person, pathway B, predictable and attuned, and pathway C, unpredictable and variably attuned. And I'll make that really simple because later I'm going to give some examples of each one. So pathway B is what we would all aspire to be, which is balanced, in other words. Pathway A is our clientele that operate from a cognitive level and they try and disassociate the affect level, so they're separating out the two. Pathway C is my naughty boys from the jail mostly. So they operate from an affect level and not from a cognitive level. So the aim in all these things is to separate out the two, the cognition and the feeling, right? So in other words, they want to be safe in one of those places to save themselves from the distress of the trauma that they've been through. Often what happens with people that go through this is that if a psychologist is doing therapy with their client and their client operates from a cognitive level normally, and when they're doing therapy, they actually get the client to get in touch with what they're feeling, and they don't take them back to a cognitive level before they leave the room. Those people can often suicide when they leave. If your patient's coming back to you and saying, every time I leave that psychologist's office, I feel worse, that's actually what they're trying to tell you. They probably can't express it like that, but they're trying to say to you, I feel worse because she put me in an uncomfortable place. She put me at a feeling level and I don't feel good there. Does that make sense? Okay. Okay, so the other presentation that you get with trauma is a presentation of increased reactivity, and we're starting to see this a lot with the refugee population. I don't know if GPs are seeing this as well, but you've got patients coming in saying, I'm having panic attacks, I'm having anxiety, I can't sleep, I'm overthinking everything, I don't know how to cope. When you see, snippets on the TV from and you see people that are actually screaming and then they'll be silent and then they start screaming again. That is how it's affected them. It has affected them from a perspective of reactivity, okay? Okay, I want to talk briefly about this one because this is a really difficult one for everybody, that whether it be in general practice or psychology practice, and that's the dysfunctional behaviour that's found in borderline personality disorder. So when I came to write this, I was trying to show that you've got the reactivity, right, on one level, you've got the avoidance on another, and then another completely different category again is the borderline personality disorder. Some people choose to prefer to call it complex trauma rather than borderline PD, but it's directly linked to one of the 4 attachment styles in infancy, and all the research that's come out in recent years has shown that the 4th style of attachment is associated with the development of borderline personality disorder. The difficulty in diagnosing borderline PD is that all the symptoms that you get, so impulsivity, aggression, sexual acting out, emotional difficulties, interpersonal, somatisation, they're equally found in complex trauma. So whether you call it borderline or PD, it's not actually that different. And so I wanted to just talk briefly about how you can screen for some of these things in general practice, which is really, really simple and straightforward. So you can download for nothing from the internet the PCL5, which equates to the DSM-5 for PTSD. And it's a screener. But it has questions related to the shutting down, and also related to the increased reactivity you get with patients. If you have psychologists that you use all the time and you're really worried about your client, they're presenting, you're not sure what is this, is it PTSD, is it complex trauma, is it borderline, what's going on here? The other thing that you can use is the trauma symptom inventory 2, which is still, even till today, the gold standard in trauma testing, and it delineates really well between PTSD and complex trauma. There's also heaps of measures that you can download from the internet and you can use for nothing. Obviously, the K10 and the K10 Plus. You can also download the GAD-7, which is for generalised anxiety disorder, the PHQ-9, which is for depression, and the CIAS, which is a social interaction anxiety scale, which actually looks at social phobia and is a pretty direct indication for diagnosis with those. Okay, so how I'm trying to bring this all together. Whenever I have a client who comes to me and their drug use is almost exclusively downers or CNS depressant drugs, then I start to think trauma and maybe developmental trauma, because this is the association that you find. So this is when you get the use of downer drugs such as heroin, endone, oxycodone, alcohol, benzodiazepine medications. And what they ultimately are is a form of chemical dissociation. So for all your patients that involve themselves in this avoidance of their memories and how they're feeling about things, what these drugs give is chemical dissociation. And sometimes people cope very, very well for many years by using drugs to disassociate from how they're feeling. So I've just got a few stats which thankfully are the same, very similar to Jenny's. So in relation to alcohol, there were fewer Australians drinking quantities of alcohol which exceeded the lifetime risk guidelines, fewer 12 to 17-year-olds, but people in their 50s and 60s were drinking more than 11 or more standard drinks in one sitting. This is research that came out in Insight last month or the month before, so it's very, very So So in 2016, the misuse of pharmaceutical remains high, mainly codeine. Whilst the prescribing of morphine decreased, there was a rise in prescription rates for opioid medications, particularly for older adults. And this is something that we actually see in psychology practice quite frequently. So for many individuals, the use of alcohol, benzos or opiates helps them control the intrusive memories, the flashbacks and the dreams related to the original trauma. So the way I always try and distinguish with a patient what they're using, how much they're using and why they're using, I never ask them, particularly if it's an opioid like heroin, I never ask them, how much do you use a day? Francis and I worked together 30 years ago in drug and alcohol, because the answer usually is as much as I can get. Right? So I ask them, how much do you need not to be sick? Right? So if we're talking illicit opioids like heroin, it's questions like that to get them talking about it.